So our plenary speaker is Dr. Nikki Hexter from IBM Watson Health that focuses on artificial intelligence solutions for improving healthcare. Dr. Hexter is an international expert on resolving the many challenges in healthcare and life sciences with data, artificial intelligence, and cloud. He is professor at the Tilburg Institute for Advanced Studies, teaching and coordinating the business analytics and business intelligence track. We are delighted to have Dr. Hexter speaking to us on the role of eHealth in the future of healthcare. Dr. Hexter.
Hello, everybody. Good morning, good afternoon, good evening. We will discuss today the role of eHealth in the future of healthcare. And there are many things to say about that, but in the 50 minutes I have, I will explain you the basics of that. So this is my disclosure. And let me first dwell a little bit on the 4 waves of industrial revolution we have seen in the past. And there were a couple of technologies that disrupted our society, like steam and electricity. But from the 50s till the year 2000, maybe 2005, we saw the advent of large computers, smaller computers, handheld systems, robotics, but also of the internet and ICT technology taking off in an exponential way. And that's where eHealth arises. And eHealth is born in this age. I think maybe the term first appeared in 1999. And today we see really a revolution in data, and we need intelligence for that. So there are many technologies also used for medical purposes that make use of data, and I'll come back to that a little bit later. So what exactly is eHealth? Well, it's a catch-all term which comprises many technologies which are making use of the internet, for instance. So it could be telemedicine or video consulting, could also be mobile phones coaching a patient. But it has also deep ramifications in other things like integration, interoperability, and maybe legal aspects. So there are many definitions. Some people talk about health 2.0 or digital health, and that's all the same. So there's no one single definition, but all these technologies that you see here are included. And let me give you some examples. So here are some examples. I show you some technologies. I won't discuss them all, but for instance, in the middle, you see virtual and augmented reality of surgeons that are starting an operation and just before they are looking at the heart. You can print even the heart for maybe educational purposes and color it. And you see this man lying with his back towards us, and that's the HoloLens who's working there. So there are many of these things that we have today, thanks to the rise in technology and the new things we have around us, and are more or less being part of our society, or becoming a part of our society. So also in healthcare and life sciences. So one of the things which are researched, and there's a great interest, is lab on a chip. So what you see here is a chip where you drop some blood, and because of the capillary function and capabilities, it's sucked into this system, which is a very small, like a chip, and it analyzes the blood. And this is used, for instance, in HIV infections for counting the number of CD4 plus T lymphocytes, but there's still a lot of research in this biosensor and bioelectronics. So for instance, this one, lab on a chip, also for HIV, and here's another one that can detect different viruses, amongst them HIV, and I've put the references, so if you are interested, you can take a further look there. But this is a very active field. Here's another one, even a wearable. I had it on my screen, wearables and swallables, but wearables are very common in healthcare and life sciences. This is a wearable for rapid detection of the HIV-1 DNA. And so you see it's like a wristwatch, and that it works together with an app that determines whether or not something is present. So in short, there's a lot of potential for e-health tools. So you see the Vitruvian man here at the right-hand side with his smartphone, fitness trackers, smartwatches. But at the same time, this imposes a bit of a problem, because there are a lot of different tools out there that are maybe aiming at the same goal, but they might not be gauged in the same way. They might not be using the same standards, and that's one of the problems. Are all these tools clinically relevant? But the big challenge is the holy grail, I would say, how to distill insight and more knowledge about the patient from the data that we can gather from these tools. And I'll come back to that a little bit later. But there's an abundance of tooling here, and I think that in the future we will see more of them, and clinically relevant tools anyway. So this is an example I took from Diabetes Care. This is an app that is really a personal coach for the patient in question. It's not a diabetes app that takes your blood values or your sugar values and puts it in a nice graphic. No, this is more. It takes into account the whole context of the patient in question, like exercise, food. He can even take a picture of the food, and the system would calculate the calories involved, and it takes into account the data from all the patients that are using this, and there are thousands of them. And because of that, the app can project a low blood sugar event just up to 4 hours in advance, where the state of the art was a half an hour. So this is an extremely good example of how data can be used to improve the life of the diabetes patient. And it achieves also extra time, even in hyperglycemia events and also hypo events. So this is how this could work. And there are apps for HIV and AIDS. Most of them are just information gathering, both for the patient and for the professional. But you see this Happy app, which is a Dutch app that's more involved. That's really a coach. So it looks a little bit like the app I showed you before. But we will see more of these apps, and of course they need to be certified, but put together not only by ICT people but also doctors. And that's exactly what happened to the Happy app, but it's more and more. And also chatbots are something that is very common now in healthcare and life sciences, thanks to the ICT technology, thanks to artificial intelligence and natural language processing. And you see here the Health App of Dr. AI from the US, Babylon Health from the UK, and Baidu from China. So from different parts of the world, this is used, and there are many of them. And one of them is Marvin, which engages HIV patients in their antiretroviral therapy, and will be discussed, I think, during this conference. So we will see more of that in the future. So it's really a combination of natural language processing and ICT technology that's here. Now, let me dwell a little bit on artificial intelligence, which is one of the fields that is upcoming. And there are a lot of applications. I will show you in a minute a couple of those that are even FDA compliant. But it's a combination of computer science and many more fields, as you can see, ethics, law, and philosophy. But the aim is to create intelligent machines that work and respond like us humans. And there are many, many technologies and specialities in AI. So don't think that AI is machine learning, and maybe you've heard of that, or is natural language processing. There are many, many technologies under the roof of artificial intelligence. And here is a list of well, this is not the total list, but it's a nice list of applications in healthcare and life sciences that have been approved by the FDA. And so this is great, and I'm sure that in the future applications for HIV, AIDS will arise in this list. So how would you apply artificial intelligence to HIV? It could be diagnosis, could be therapy, it could be population health, prevention. All the angles can be, well, they carry data, so you can do something with artificial intelligence. And if you go to the literature, then you see this is maybe an older paper, 3 years old, but it also projects how you could use the data and these deep business analytics technologies to the HIV/AIDS pandemic. Here's another one, machine learning and HIV to end it. And I checked with PubMed line, and you see an uptake of papers that are writing about HIV and artificial intelligence. So I think this is a field from which we will see more in the future. And just to give you one example, there's an abundance of literature, around HIV and viruses in general. On PubMed line, every 30 seconds a new summary is being published. Every 30 seconds. Not everything has to do with HIV, of course, but maybe a couple of papers per day. By the end of the month, you have a pile of papers that you need to read. But you can use technology here. There's something called medical literature search, which enables you within seconds to go through this mountain of literature on the basis of syntactic and semantic search. Because it's really impossible for the doctors and the researchers to keep abreast with this field, because the volume and the rate of change, sorting it out, combining or connecting the dots in the literature. So there are many technologies now available to help you to find new drugs more quickly, to find new treatments more quickly, because you can lay your hands on the vast amount of papers that is available. So this is just one of the applications of natural language processing and machine learning in this field. Finally, there are of course challenges, because not everything can go into healthcare and life sciences processes. You need some certification. For instance, there is regulatory aspect. What are the legal implications? What's the liability with these systems? It's like software as a medical device, for instance, or just a plain medical device that needs quality label, CE marking. Is it GDPR compliant? All that kinds of things needs to be tested. There's also an economic aspect. Who is going to reimburse it? This is something new most of the time. Who's going to purchase it? Can we get that from the hospital? Who is going to do that? Structural, doctors, students, researchers need to adopt. They need to learn about this. But also you need to test in a scientific method the sensitivity and the specificity of these new e-health applications. And you need to have maybe new curricula at the universities where you insert e-health and maybe analytical methods. And last but not least, there's a technological factor, because you need a good platform maybe, or an infrastructure that's able to capture data, but also to exchange data, and that needs standards, interoperability standards, and integration standards. So these are a couple of challenges, but people are actively working on all these aspects, and there are more. This is not an exhaustive list. Anyway, I see a bright future for the application of e-health, and especially artificial intelligence and natural language processing, machine learning in the field of viruses, HIV and AIDS. And with that, I hope to have given you a brief introduction into this field. Thank you very much.
Oh, thank you very much indeed, Nikki Hexter. That was a fantastic talk. And I hope that in the round table we can do a little bit more delving into the role of e-health. But we're moving on to our round table, which is about technology and medicine experts. And we're going to have now 5 talks from renowned experts on medical technology. Our first speaker will be David Back, who I think almost everybody knows, from the University of Liverpool, and David's emeritus professor of pharmacology there, and his career has been spent for many years on HIV and drug interactions. And of course, he hosts the drug interaction website for HIV. We would just call it the Liverpool website. Whenever you say that, it's David Back and his team, but they also do it for hepatitis as well. So that's wonderful. We're then going to have Dr. Robert Schaefer, who is Mr. Resistance. He's the creator of the Stanford database, a fantastic public resource. He's professor of medicine at Stanford University, and we're going to hear from him about the database. We're then going to move on to one of my colleagues, Gary Whitlock, Dr. Gary Whitlock from 56 Dean Street. And Gary's got a huge interest in service enhancement, in PrEP and gay men's sexual health. And we're going to hear about how 56 Dean Street have used technology in interacting with patients. We then move on to Jenny Wetham, who is she's a coordinator of the Emerge project, which is one of the EU Horizon 2020 projects. And Jenny's a consultant at the Brighton and Sussex University Hospital Trust in Brighton. So really looking forward to hear about the Emerge project. And then our last talk is from Mohammed Al-Ubyaldi, and he is the CEO of Patient Knows Best. And many of my patients use this app. Dr. Ubyaldi is a physician and has written many books on patient records or things related to that, and is a super expert on issues around patients' involvement in their own healthcare and in keeping their own records. So it's going to be a fantastic 5 talks now, and then we'll be back for our question and answers, and I'll be joined by the co-chair Jonathan Shapiro for this. So we're going to have a lively time. If you've got any questions, please make sure that they get put into the chat so that we can ask our experts when they're on. So with that, our first talk by David Back.
So I'm going to talk about the University of Liverpool drug interactions prescribing tools in the areas of HIV, hepatitis, cancer, and COVID-19. The problem we face is with HIV, 37 million infected worldwide, hepatitis C, 70 million infected worldwide, cancer, 1 in 4 deaths in the UK from cancer, and COVID-19 with the latest estimates of more than 40 million cases globally. Many of the drugs used in the treatment have a high propensity for drug-drug interactions. We need to consider the harms, and the harms from drug-drug interactions are documented in some studies and case reports as shown in this montage of publications covering both antiretroviral therapy and direct-acting antivirals for hepatitis C. Pregnancy, for example, with a loss of contraceptive efficacy, cardiovascular complications, Cushing syndrome, corticosteroid overemphasis, and then fatalities in people who used drugs. Our story is we started out in 1998 with the first HIV charts as a result of the advent of protease inhibitors with boosters. We had a fully interactive website in 2006 with an international editorial board in 2009 and the implementation of a grade system for the strength of recommendation and the quality of evidence. We redeveloped the HIV site and with the app in 2011, and a hepatitis site and app for both iOS and Android in 2011. We produced in 2017 a cancer website and app, and then in March 2020, a COVID-19 website with an app to follow. Our mission is to provide clinically useful, reliable, comprehensive, up-to-date data, which is for drug interactions, and these resources are freely available to healthcare workers, patients, and researchers worldwide. We have a strength of recommendation based on a color coding with quality of evidence from very low through to high. So for example, in the HIV site, you can search for a primary drug, in this case, bictegravir FTC TAF, a co-medication, in this case being omeprazole, And it gives you a commentary of the interaction. Here it is green, so no interaction expected, with the evidence being very low. A PDF report can be downloaded and put into the patient notes. But if, for example, you get a red color, this is for darunavir cobicistat as the primary HIV drug with clopidogrel and dabigatran. You can also search for an alternative to the red colored drugs. And in this case, you can see a list of anticoagulants and antiplatelets, which potentially could be used as alternatives. You can also search for a number of primary drugs. Here we have 4 integrase inhibitors with a number of co-meds that a patient may be on. And you can see the more risky areas for drug interactions. In this case, because of the booster, you have more drug interactions with elvitegravir cobicistat. The HIV site, the statistics, a total of 42 antiretroviral drugs or regimens with 800 co-meds. 29,000 users visit the site each month. In the first part of this year, over 2 million interaction searches were made from a number of different parts of the world. Guidelines, we're in the European guidelines, and these are the latest guidelines from October 2020. For the hepatitis drug interaction resource, there are 23 drugs for treating both HCV, HBV, hepatocellular carcinoma, and primary biliary cholangitis, with 800 co-meds, each month 14,000 users, over 1 million interaction searches so far in 2020, with a reach to many different parts of the world. Also in the EASL guidelines for hepatitis C, charts are taken from the website. The COVID site launched in 2020, 100,000 visits in the first month, 20 experimental COVID therapies and 500 co-medications. Most frequently searched COVID drugs being remdesivir, hydroxychloroquine, lopinavir, ritonavir, chloroquine, azithromycin, with a worldwide reach. We have translations for hepatitis into Japanese, for HIV into Spanish and soon to be Portuguese. Electronic prescribing is also something that an API from the database of the Liverpool resource can feed in to different electronic prescribing systems. And here we have Malago Hospital in Kampala. Our users say that this is a very important resource. So World Health Organization for HIV say that we rely on the information provided to develop global guidelines for treatment and care of people living with HIV. And similarly, from the liver community, the EASL guidelines use the site, and this is a major influence on HCV treatment practice worldwide. And so my acknowledgements are to a wonderful team who do so much of the work providing up-to-date resources, not only the websites and apps, but also many other prescribing resources for therapy areas in treatment selectors, and also different resources for individual patient conditions. Thank you.
Thank you. I am glad to be here to tell you about the Stanford HIV drug resistance database. Here are my disclosures. And the funding for the database comes entirely from the Division of AIDS at the NIH. The Stanford HIV drug resistance database has 3 parts: an actual database that can be queried, several sequence analysis programs, and many educational web pages. In this talk, I will describe the most widely used part of the database, the Genotypic Drug Resistance Interpretation Program. You can access the interpretation program and the pages containing supporting educational material at the upper right part of the home page. Clicking on the HIVDB program tab will take you to the most commonly used form for entering data, the one that allows clinicians to enter lists of mutations in the RT protease and/or integrase genes. Laboratories and researchers performing the actual virus sequencing will use different forms that allow them to enter the raw sequence data. The mutation entry page contains 3 parts: the lists of drugs to be included in the report, the text boxes for entering mutations, and the optional drop-down lists for entering mutations. The default list of drugs included in the report includes 6 NRTIs, 5 non-NNRTIs, 3 protease inhibitors, and 4 integrase strand transfer inhibitors, or INSTIs. The cytosine analogs, 3TC and FTC, are treated in an identical manner by the program. The same applies to the 2 tenofovir prodrugs, TDF and TAF, although this is continuously being revisited. Cabotegravir will be added to the default list when it is FDA approved. There are 3 text boxes for entering mutations, one each for RT, protease, and integrase. Mutations are defined as amino acid differences from a consensus sequence. However, it is not necessary to know the consensus because, as shown here, it is just necessary to enter the mutation's position followed by the amino acid or amino acids present in a patient sequence. It is not uncommon for a sequence to have a mixture of 2 or more mutations at the same position. And when this occurs, each amino acid is listed following the position. Selecting mutations from the drop-down list is optional because most clinicians will be copying mutations from a genotypic resistance test report. If a mutation is selected using the drop-down list, it will immediately appear in the text box. The bottom part of this slide contains a sample list of entered mutations for RT, protease, and integrase that we will be using for the following slides. This slide shows the NRTI plus NNRTI portion of the report for the sample with the mutations entered on the previous slide. It contains 3 sections: the interpretation section, the mutation scoring section, and the mutation comments. For each gene, the mutations are classified into 3 categories. For RT, these are NRTI drug resistance mutations, or DRMs, NNRTI DRMs, and other mutations. For protease and integrase, these categories are major drug resistance mutations, accessory drug resistance mutations, and other mutations. The other category is for mutations that do not contribute significantly to HIV drug resistance and are often naturally occurring variants. For each drug, there are 5 susceptibility levels. The clinical implications of each of these levels are described in detail in the program's release notes. For each drug class, the output contains a table showing the mutation scoring that led to the interpretation. For each drug, these tables list mutation penalties that, when added together, are converted into a level of reduced susceptibility. Mutation penalties can be assigned to individual mutations, as shown for the NRTI DRMs in this particular example, or to individual and combinations of mutations, as shown for the INSTI DRMs in this example. Combination scores are particularly important for ARVs with a high genetic barrier to resistance, such as the 2nd generation INSTIs, as shown in this example. Several mutations can increase susceptibility to a drug, and these receive negative scores for that drug. For example, M184I increases susceptibility to AZT and tenofovir, whereas K65R increases susceptibility to AZT. There are 4 pages containing the complete list of scores for each drug. The third part of the report for each drug class is the list of comments for each mutation. This slide shows the RTI comments and the INSTI comments for the sample we've been using so far. The comments contain data that may not be reflected in the mutation penalty scores. For example, the M184I V comment states that although these mutations cause high-level 3TC and FTC resistance, they are not contraindications to the continued use of these drugs because they increase susceptibility to AZT and tenofovir, and they reduce HIV-1 replication. The comments also indicate which mutations are polymorphic in that they can be observed in previously untreated persons. There are 4 pages containing the complete list of DRM scores for each drug class, and 4 pages containing reviews of the DRMs for each class with cited references. 3 main types of data are considered in developing the mutation penalty scores. The first is the extent to which a mutation is selected by a drug or drug class, as evidenced by the prevalence of a mutation in ART-naive and ART-treated individuals. The second is the extent to which a mutation reduces susceptibility in vitro. The third is the extent to which a mutation influences the virologic response to a drug. Although one might consider this third type of data to be the most important, it is incompletely available for most mutations in drugs. Finally, expert opinion gleaned from published papers and scientific meetings also plays a role. In conclusion, a single genotype cannot be used alone to guide therapy. It is also important to know whether a person with HIV had other earlier genotypic resistance tests and whether virological failure occurred with any previous regimen, even if genotypic resistance test results obtained at that time are not available. Finally, the results of genotypic resistance tests must be placed in the context of current treatment guidelines because not all possible combinations of antiretrovirals are viable options. Finally, I'd like to acknowledge the HIV-DB team members who are listed here: Jonathan Shapiro, who is the director of the advisory committee for the HIV genotypic resistance test program, and the NIH for funding.
So these are my disclosures. I'm going to talk about the service that I work at, 56 Dean Street, 56DS, and I'm also going to describe rapid diagnostics, how we use them in clinic, primarily for STI management, but also how we've used it further in PrEP monitoring, but also HIV follow-up. So 56 Dean Street is the service that I work in. It's the busiest combined STI and HIV service in Europe. We have about 150,000 attendances in the clinic per year. And we manage people with symptomatic and asymptomatic STIs, but also people living with HIV. So in the bottom left-hand corner, you'll see a brown building, and on the first 2 floors is where we see people for STIs. The 3rd floor is people living with HIV. The top floor is for admin purposes. And in the bottom right corner is Dean Street Express, which opened 6 years ago, which is our service which manages people who have asymptomatic STIs or asymptomatic STI testing. And I want to describe that in detail. So this is Dean Street Express. It looks like a hairdresser's, but it's actually a clinic. And the patient flow is such that when patients come into the service, they register directly into the computer system using their card, which they scan in, and then they directly input their sexual history into the electronic patient record using touch screens. There's no paper used. Then they proceed to dedicated booths at the back of the clinic ground floor, where they proceed to take samples for chlamydia and gonorrhea testing. So that may very well be from their bottom, from their throat, vaginally, and urine samples for urethral testing. There are dedicated videos. You'll see a video here of someone doing a throat swab so that patients who've not done it before know what to do. And then samples are podded in the blue pod that you can see here directly to the in-house laboratory. And this in-house laboratory has a Cepheid gene expert machine, which performs the processing of nucleic acid amplification tests using real-time PCR, and the results are obtained in 90 minutes. And those results are then texted directly to patients' mobile phones with instructions about whether they're positive or negative and what to do if the test is positive. Now, once patients have swabbed themselves, they can proceed to a clinic room where a nurse will review the history that they put into the touch screens, and they can have blood tests taken which are performed in a nearby laboratory, and those results are obtained in 6 hours. So the whole of the STI screen for chlamydia, gonorrhea, and any blood testing, you'll get the results in 6 hours. So rapid diagnostics has really changed what we do. So this is looking at how we get the chlamydia and gonorrhea results from the Gene Expert machine at Dean Street Express, and how that has changed since we introduced rapid diagnostics in-house. So before we introduced the Dean Street Express service, people were getting their results in about a week. Now the paradigm has shifted and people are getting their results in a matter of hours. And this is not only more efficient in terms of staff costing, because staff aren't doing the testing, the patients are testing themselves, but because STI results are now in hours, there are public health benefits and further cost benefits. And if you look at the paper below, then we can talk about that in a bit more detail to describe the real benefits to services adopting this. Since we introduced Dean Street Express 6 years ago, we've begun doing PrEP monitoring, and this is being done more and more at Dean Street Express. And if you think about it, PrEP monitoring is just exactly what we've done, an asymptomatic screen, but an extra blood test for renal function and a urine dip. And this can both be done in a very similar way in the Express service. And so the benefits of that are same-day prescribing of PrEP, which is very much in the news at the moment, and it's also a nurse-led service. So it allows us to see a large capacity of people. We do have a senior doctor weekly clinic for face-to-face contacts with complex patients who are identified in the nurse-led service. And the outcome of that, if you look at the red line, is people buying PrEP off the internet and coming to us for monitoring. This built fairly slowly since we introduced PrEP monitoring. But look at the green line. This is the impact trial where people get PrEP from us on a research trial. And when it opened in the autumn of 2017, we got 2,000 people almost onto PrEP within 2 months using rapid diagnostics. We also, this is the 3rd floor at 56 Dean Street, the HIV clinic. We also use rapid diagnostics there. So behind the water cooler is a booth, not unlike at Dean Street Express, where patients can put in their history for sexually transmitted infections. This is during a 6-month check. So every year patients see doctors, but in the intervening 6 months, they see a nurse. Having given their history into the machine, they proceed to swab themselves, such as at Dean Street Express. The nurse will take a viral load, which gets processed in 6 hours and will dip the urine. And the great benefit of this is it reduces doctors' appointments, so increase the capacity within clinic to see patients, and all results are available on the same day, texted directly to the patient. And of course, that reduces the need for results checking within clinic and is much more efficient. Thank you.
Thank you for inviting me to speak today on the eMERGE project. eMERGE has been a 5-year Horizon 2020 funded project involving a consortium of 12 partners, including our 5 clinical sites in Antwerp, Barcelona, Brighton, Lisbon, and Zagreb. These are my declarations of interest. So within the eMERGE project, we have co-designed, implemented, and evaluated a digital health pathway for people living with medically stable HIV. We've had a high level of community involvement throughout the project, led by our project partner EATG. In the first year of the project, we did a detailed background assessment at each of our 5 clinical sites and started our co-design process, which has run iteratively throughout the project. This study was conducted pre-COVID, but I think its learning and findings are particularly pertinent at this time. So within the pathway, individuals were seen once a year by their clinician, with the interim 6-month visit carried out using a digital health platform. The eMERGE platform consists of a clinical web application which sits inside the hospital firewall and integrates with the clinic database via an API. Once results and data are reviewed, they are encrypted and then pushed through the cloud to a co-designed application on the individual's mobile device. There's no data stored on the phone and all is GDPR compliant. The application receives results, appointments information and antiretroviral details. Reminders are programmable within the app or within the individual's calendar. Frequently asked questions and health promotion information is available. And there's a notification function which sits alongside the messaging, but also means that messages and notifications can be sent to all users, and this has proved really useful during COVID for communication about COVID and about service changes. I should just emphasise that the messaging within the study was one-directional and didn't include video consultations or two-way messaging, although we have since developed both capabilities. We integrated the platform at each site during 2017, showing its adaptability to different IT settings, which varied from a local area network of 3 computers with data held on Access initially, through to clinic databases in SQL and hospital information systems. We used the MAST framework for our evaluation. MAST is an HTA type technology that was developed for assessing telemedicine applications as part of an EU study. Once the preceding factors were met, we invited people from each of the 5 sites to participate in the study, and our inclusion criteria are shown here. As well as collecting data on virological outcomes and visits, we asked people to complete a questionnaire pack at baseline and then every 12 months. We conducted systematic reviews to look at suitable outcomes for empowerment and also for quality of life measures. You'll hear from Richard later, but we were also able to validate the BEVA positive outcomes prom as part of the eMERGE study. Eddie Beck and his team ran a health economics analysis and carried out micro-costing studies at each of the sites. So, to some results headlines. The study opened sequentially in 2017 between April and November, and enrolment was open for up to 18 months. Overall, 2,251 people took part in the study, which represented around 23% of each cohort. This varied from between 10% up to 47% of the different cohorts. The primary outcome measure for eMERGE was related to a change in PAM13 score between baseline and month 12. In the event, this was a highly activated population, and we saw no clinically important difference between these timelines. Health-related quality of life information, we've got lots more data to follow on this, again showed no change between baseline and month 12 as anticipated, but did underline the fact that this fourth 90 still has some way to go. Where problems were reported, this related to pain and to anxiety and depression. And in ProQual HIV, participants scored highly in all domains apart from stigma, which varied by site. As one would expect, but very reassuringly, viral load outcomes remained very good throughout the study. So in all of the study follow-up, we only had 10 individuals who had a viral load of more than 50 copies per mil on 2 consecutive occasions, and none of these were lost to follow-up. We monitored for SAEs throughout the study and beyond, and there were no SAEs related to the pathway or platform. There was a reduction in visits to clinic, again as we'd anticipate, of up to 30% for face-to-face visits, with associated reduction in costs for these individuals. Overall, the costing studies and costs related to HIV care were largely driven by antiretrovirals, as we would anticipate. There was also an ecological benefit to the reduction in face-to-face visits, and usability and patient experience was very good. To give a case example of one of our sites in Zagreb. Zagreb is the only HIV centre for Croatia, led by Professor Josip Bekovac. He, his team and community colleagues at Lux Vitae describe well the benefits and challenges of introducing a digital health pathway. They have been extremely positive about the process of using digital health frameworks to empower communities to participate in service redesign. What we have done has been quite simple, but it has worked. The study was conducted pre-COVID, but our learning is particularly pertinent in these times. Digital health provides a lot of benefits when used as a person-centred approach. It's an option in the menu of care. It doesn't necessarily suit every person at every time, but I hope that we've shown here that this pathway is a feasible and acceptable option for many people living with HIV. There is still a lot of work to do to address the digital gap and digital health literacy aspects as we all move forward through these new times. I'd like to acknowledge all of our partners and to pay tribute to Martin, whose vision this project was. Thank you.
Thank you for inviting me to the workshop on healthy living. My name is Mohammed. I'm the CEO and founder of Patients Know Best. I'm basically a geek. I trained as a physician and programmer, and I wrote 6 books about using IT in healthcare. One of them was how do you share medical records with patients? And I became particularly obsessed with the problem because I have a genetic immune deficiency myself. So I thought back to all my appointments when my physicians rely on me. I tell them what the other physicians did, and I give them advice on how they treat me. And I realized they trust me with my treatment, not because I went to medical school, but because, like all patients, I went to all the appointments. And so as I wrote the book about giving patients access to their record, I realized how many situations I could improve the quality of the consultation for myself and improve the ability of my physicians to help me and to look after me. This is not just a problem for rare diseases. It happens in every situation, for every patient, in every health geography. Different people try and solve this in different ways. Some take an institutional approach, some take a disease-based approach, some try and do it with apps and devices. The problem is healthcare continues to get more fragmented, and that's before we even think of the patient themselves as a provider of care. So the approach that we take is that all the data about the patient goes in one place. That's a record owned by the patient, and the patient makes the data available through the correct consent to every provider looking after the patient. We started in 2008. Right now we're the largest personal health records company in Europe, and we have contracts covering 20% of England. 12 million lives are covered through our system. And it's the system that's recommended to hospitals in England by the NHS Innovation Technology Payments Programme. Now, what does this mean in practice? The heart of this is the ability of the system to give the patient consent. The patient decides which part of the records to open up to which medical professionals, like the general, the sexual, the mental, and the social care data. And the patient opens up maybe everything to their general practitioner, and maybe it's only some things to their physiotherapist, for example. Then you can start getting the benefits of the patients working in digital fashion. So if you send them letters, they look at the data. About 70% of them look at letters within 48 hours. About 50% of them see it within 2 hours. That means you can avoid postage, but it's not just avoiding £1 in postage for the appointment, it's avoiding the appointment for £100 or preventing the A&E admission for £1,000. Then you can start doing things with patients. This is the sexual health clinic in Plymouth. They made the messaging system available to patients during lockdown. The power of secure messaging across providers is that you get the security, so you don't have photographs of sexual health images on a physician's phone if they're using WhatsApp or email, for example. You get the safety, knowing that it's not stuck in one clinician's inbox, actually available to everyone in the team looking after the patient. And you get the accuracy. The photographs you take are actually much better than trying to do a screenshot during a video call. The patient has enough time to take the right photograph, they get the right lighting, and they give you what you need to make a diagnosis for the patient. You can also give test results to patients. This is Paul, he's a patient in Northwest London, and he gets his HIV test results. As you know, most patients are stable with HIV. They may get 3 appointments a year. They only need 1 to actually do the physical examination. And the rest, they're just asking, what's my CD4 count? Now, if you can give them that information without them coming in, many of them are working age, they don't want to take half a day off work for a 10-minute appointment. And if you can give them that real time, that's more convenient for them, but it also increases the safety of care as they go abroad and they travel with their information. This is Reston. He then used the system he's a surgeon who used the system for care planning for severe trauma patients. The care planning functionality is really powerful because you can actually embed videos, websites, explanations, video of how to use an inhaler, how to wash a spacer, how to inject yourself with medications, and then instructions on what to do in different situations, what to do when things are going well, what to do when things are going badly, and when to escalate and come to A&E. Now this actually works in practice at large scale. So we have the records of patients across the UK in every county with hospitals in most regions in the UK. But it all started really in 2015 with Imperial. This is John Kelly from Imperial, who led for Northwest London, putting the patients in control over a population of 2.3 million people, 400 GP surgeries, 16 hospitals. This was the first time in the world that all the medical data was placed in the hands of patients and they could decide who gets access. Now that solved all the information governance problems, and you can then deliver better care. Next year in Wales, this is Sam talking about her father and how he gets his test results, and that lets her look after him. This was part of a national integration in Wales, where the data comes for patients in Wales or being looked after by a Welsh provider. And then it spread internationally. This is Lucian in the Netherlands. He led on chronic myeloid leukemia, the national standard being Patients Know Best. Really, this is about delivering something across entire large geographies. What came out in March of this year was the Nhs App integrated with Patients Know Best. As you know, the Nhs App in England gives patients access to some of their GP data. PKB gives access to all of the data from the NHS, including hospitals, test results, but it also gives the patient the ability to put in their own data, so their symptoms, their home devices. They can do shared care planning with the patients. And that's why even the disease-based approaches have switched to using PKB. This is the renal portal in 72 hospitals. They've all switched to using Patients Know Best. I'll stop there. If you'd like more information, please visit our website. Thank you for watching this presentation.
Oh, fantastic. They were great talks, a stellar lineup, and I learned, as usual, a huge amount. And now we're going to go to the round table. We've had some questions in the chat. Now, I just want to talk to Gary. Gary, referral to medics in 56 Dean Street. I mean, why do you need the doctors there?
So we're following up, we think, in excess of 10,000 people on PrEP. So there are various reasons why they might refer to the medic. So we're really lucky we've got Sheena McCormack, who ran the PROUD study. So she does a weekly clinic with us. So the most common thing is people who have side effects to PrEP or perceived side effects to PrEP, potentially drug interactions that may be relevant, that can't be dealt with at that time, comorbidities, so people with renal problems or hepatitis B. With over 10,000 people on PrEP, we're bound, even in a healthy cohort, to have people that have questions that just need a bit more addressing. And there's no way that we could follow up that number of people without that expert help.
Okay, no, that's great. Yeah, and they get high quality care there, which is when you can see the amount of things. Do you think it's all compartmentalized? Do you think it should be brought together, or do you just think that this is just examples of what's happening?
Yeah, this is, but that is how it starts. What struck me was the platform for the patient and the doctor, where you gather this information, exactly as I told you, that we need this capability of gathering this data from the patient and then do some intelligent things with it and bring it back to the patient. And of course, of paramount importance. I mean, you need reliable data sources, whether it's captured in a portal or maybe in an app, or can be approached by an app. But these are all the starters and the beginnings of, and it's a tremendous amount of work. I have deep respect for the people who do that to get it going. So I see, so what it learned to me is that there is an active group of doctors who's actually taking the lead and try to embrace ICT technology to make this all better.
Yeah, great.
Anton, along those lines, actually, you know, I'm thinking about this and looking at all these amazing technologies, which are these amazing tools, and I guess looking back at the Stanford database and the Liverpool website, which I think for many of us have now become sort of standard of care in management. But looking 20 years ago wasn't so. You know, 20 years ago there was a lot of debate whether this would work, and there were different systems. I want to ask both Bob and David a little bit about publications and objective studies. Both Stanford and Liverpool have invested a lot over the last 2 decades in very objective studies and publications. how large a role does that play in allowing these technologies to become standard of care? You know, Bob, David?
Well, this is Bob speaking about the drug resistance database. I think the fact that we published a lot about the data in our database gives the database a certain credibility, and people become familiar with it. But it's very hard to actually do studies to prove that the drug resistance interpretation system that we have works better than not using such a system. So those studies are actually quite uncommon and difficult to do. But I think that's the same with a lot of interventions in HIV care, like even virus load testing. It's hard to prove that that's useful, but we all believe it is, or even drug resistance testing. It's very difficult to prove that that's been helpful. So mostly what we've published has been helpful for gaining credibility and for educational purposes, but not really proving that this is an essential tool.
David? You're muted, David. You're mute. David, you're on mute. You can unmute.
Yeah, sorry. So I think it's the same issues that Bob raised. I mean, what we've tried to do is to link an API into huge databases such as the Swiss HIV cohort, for example, and a big database in Madrid where they've got over 6 million records, and therefore try to get publications from those sort of large cohorts, but actually proving that you're saving patients from harms is actually quite difficult to show. And I do think we need to move to the next stage. And what Nikki said, I absolutely take on board that in one sense you have a starting point, and how do you go? And we've discussed this ad nauseum in a sense, is how do we get to the next stage beyond having one focused app, which could be far more integrated into bigger systems. And any help and any advice is certainly welcome.
Well, we have you have a direct line to him now.
Back to that. I mean, I see much of these projects being started within the hospitals, within the walls of the hospitals. But at a certain point of time, you need help from the ICT industry, and whether it be IBM or maybe Google or Microsoft, it doesn't matter. But we are the experts in bringing in constructing APIs, and making the connections. Standardization, integration, interoperability, all those things, and also scale it, and that would help you enormously. So again, I have deep respect for what has been achieved, but there will become a certain moment in time when you need to reach out and collaborate, because you cannot do it without us, and we cannot do it without you. So there needs to be synergy between the ICT industry and the medical world.
Mm-hmm. It's great, yeah, and the more of that goes on, the more we can develop things and make them work better. So, Mohammed, I really enjoyed your talk, but there's a question about legal barriers when you had to implement Patient Knows Best in the UK. Were there any problems with that?
No, but there were perceived problems. So pretty much any legal jurisdiction, we operate in lots of countries all over the world, no matter what the political system, the one party that governments accept as allowed to have data about the patient is the patient. So if you give the data to the patient, they can then give it to everyone else, whether it's clinicians, researchers, family members, and so on. So to me, it solves a lot of legal problems, but it is a new model for many professionals, many institutions. And so a lot of them initially think, oh, I'm not allowed to move the data or share the data, rather than understanding that actually this is what does allow me to share the data. So a lot of our work in the beginning was educational, just explain to them the legal framework, and that this solves so many problems they've had in the past.
Oh, great. And Jenny, I mean, all the projects you've heard about sort of started off and then were adapted by people and countries. But with you, you had to start off by getting countries together. What were the challenges there? Was it was it registrational? Was it ethics? Was it that sort of thing? I mean, I'm just curious about what barriers you had to overcome to get your project going.
Thanks, Anton. Yeah, it's been a very interesting and steep learning curve for me, and been absolutely fascinating as we've worked across 5 different settings. We've been really fortunate with the colleagues that we've worked with in the consortium, because everybody was really able to put the project to the forefront, and through EATG, the support across the community has been incredible for the project as well. And I think it's finding that common understanding of the issues and working together to solve them that's really sort of worked for us. Everything was within Europe, so it all needed to be GDPR compliant from the beginning. So from an IT and information governance framework, we had obviously a very clear set of standards to work with. And it was building those trusted relationships in the hospital to get people's buy-in, and having clinical leaders in each of those places was absolutely key to getting that straight. But it took time. I think all of these things take time, don't they, to amidst the other priorities of clinical life and of hospital life as well. But yeah, the strength of the consortium has been absolutely key to our success, really.
Yeah, I just wanted to bring that in because technology is wonderful, but and I think, Nikki, you sort of made this point that people are really important to make it work, and working together isn't always easy. And as you said, Mohammed, across many jurisdictions, you've had to launch this thing. So in the last few minutes, I'm sorry, I'd really like to have an hour. We had a very good question. There's been a whole shift to telemedicine and technology during COVID. And the assumption is that when the pandemic's over, all of this shift to technology is going to endure. So what do the panel think? Do you think it's going to endure, or are we going to go back to sort of regress back to a sort of normality or a normality plus? It's just an interesting philosophical concept about how much COVID has driven technology in medicine. So, Nikki, maybe I can get the industry's point of view about where you think it'll end up when this is calmed down.
Yeah, well, by the way, there's another pandemic going on. That's HIV. Yeah? So we need maybe this technology to do something about that. But I think that it will endure up to a certain point, because I know that there are studies now being conducted to what extent telemedicine has helped the effectiveness and the efficiency of healthcare. And in mental health care, these blended technologies like face-to-face plus telemedicine is very common, and there are very good results. So I think this will endure also in normal medicine, regular medicine, and other fields. And the COVID has accelerated the usage of telemedicine. It has accelerated the creation of new legislation, because that's needed. And if that's all there, then people are used to it, and they will use it in the future. But it needs to be clinically relevant, and that needs to be sorted out yet.
Thanks, Bob. Do you think we're going to go back to how we used to be, or do you think the world's changing forever?
No, I think telemedicine is here to stay, and it's going to increase, because I think it's very convenient, and for both the patient and also some degree the physician. So I think it's here to stay, and will continue to increase as long as the legal framework, and in the U.S. The billing framework is important. But as long as those things are in place, I just see it increasing.
And David, the website must have increased its use now you've got the COVID side of it all. And are you concerned at all that telemedicine and drug interaction assessment, that which is going to start to be done more remotely? I mean, obviously you've got a tool, but then the clinician's got to interpret it. Are you concerned about the rise in telemedicine and how physicians might use your database to make decisions?
Absolutely. And I think, one thing we've always said is that the decision to give or withhold a drug is always the decision of the physician. Ultimately, we can give some information, part of the jigsaw, but it's the physician's decision. And how we have to adapt now. I think just as with climate change, we're adapting, and no diesel and no petrol in 10 years. I think now with COVID, we're adapting to the whole new paradigm. And I think it's a steep learning curve, I think, and we're certainly going to have to adapt.
Yeah, thanks. Jenny, you're a clinician, and then Gary, clinician, then I'll finish with Mohammed. Any other thoughts about telemedicine and the way you're going to work? You're going to be out of a job.
I think, I think as everybody said, COVID has really driven sort of digital health interventions in a very positive way. But I think what's absolutely key is that it doesn't become a panacea, because there are really sort of large groups of our communities and populations for who digital isn't the right thing at particular times. And, I think there's that massive risk of us widening our health inequities. So I think the key to that is making sure that we co-design our whole services with communities and clinicians, with the digital involved, but not just focusing on the digital aspect. And don't get me wrong, I'm a massive advocate of digital, but I think we just have to make sure that as we reset, that all of the changes we've made quite quickly and quite rapidly out of necessity don't become our new normal without lots of considerations about the bigger picture.
Yeah, I know. Gary, I was talking to a lot of Italian activists and community, and many of them didn't like telemedicine. They wanted face-to-face, but you at Dean Street have been using this stuff for ages. Have you found that COVID's actually expanded the ideas you have?
Yeah, so we always had a telephone clinic for 2 hours a day. Now it runs for 8 hours a day with 3 clinicians on it, so people can get through to us straight away. But I want to echo what Jenny said. I think people can fall through the cracks. And what about those people who are a bit more chaotic, who can't access the telephone or even computers? And also in a face-to-face consultation, you can be a bit more dynamic. You can give vaccines. There are things we take for granted that we just give to patients when we see them, which may very well be lost. So we might be very good at keeping people's viral load suppressed, but are we good at keeping them up with their Hep B vaccination, HPV vaccination? And I think we've got a lot of thinking to do. Yeah.
And Mohammed, have you had to adapt things to your app during this COVID period? And do you think it's going to evolve into something slightly different now?
Definitely. I mean, I've had a lot of venture capitalists quoting Lenin in the last few months that some decades nothing happens, and some weeks decades happen. I think COVID is irreversible. Now, as Jenny's saying, you have to figure out the right things and keep those and drop the bad things. But one of the biggest objections to telemedicine was it cannot be done. And then we all realized it's the only thing that can be done for a while. So the biggest thing that we do, and this is not for any educator, we provide our software free of charge to any educator, because medical schools weren't training doctors on how to work with patients online or how to work with the patient seeing the information before you see it. So during COVID, we had 12 of the UK's 36 medical schools start using us for all their students, train them across every year. If anyone would like this in any territory, please drop us a line. We'd be delighted to help the next generation get trained for this.
Well, thanks very much. That's a great note to end on. I mean, I'm sorry, we've run out of time. In fact, I've been a bad chairman. I've run us over time, but with you guys on, I really wanted to try and pick your brains. And thank you very much for the audience for questions, Jonathan for co-chairing, but really to you guys for fantastic talks and a really wonderful session as we go into the coffee break. We'll see you soon.